Oh, you see some lovely faces there. Well, lovely names. Hi everyone. Thank you for joining us. Sorry, we're a couple of minutes in. Me and Pat were just having a interesting debate on the new framework, which we'll fill you all in on shortly. So thank you for joining us. It's always nice to see our regulars back and some new names as well. So we are a month overdue for this, actually, aren't we, Pat? Because
Yeah, we are. We
there's so
are.
much going on with shows and various things.
Yes. Yeah.
But we're back, and we've got another one in July. And then I think we have August off, and then we're back in September. So
Yeah. Yeah.
there'll
No,
be
I think
lots.
there's no point in trying to do it in school holidays because it'll just be you and me chatting on our own.
That's all right. It's we can fill the time, I'm sure.
We
So
can. We can.
so welcome everyone. Thank you for joining us, and for anyone that's not joined us but is listening to this, I hope you find it useful. So as always, we're joined by the wonderful Pat Langley from Dentistry Compliance, who very kindly gives her time each month to do this for us. And we say this a lot, but we're always really shocked at how much we always have to talk about, that we don't really plan or worry.
No, we don't. We a couple of minutes, oh, this is new or that's new, or should we talk about this? And that's it. Then we could probably keep going all afternoon, but then that would eat into your time. So yeah, we keep it to an hour.
No, it's fantastic. So, Pat, we had a few minutes chat before we came on, to kind of go, right, what's new with us? And one of the things we kind of wanted to mention first of all was that we've had a wonderful practice manager breakfast that we held at Resorts World at the last Birmingham Dental Show. And it was the first one we've done.
Yeah.
Um, and it was supported by Decky's given us a little heart there. Decky was
Yes, yes. Decky was
Decky was
there.
there. So we basically held with Dentistry Compliance. They very kindly hosted a breakfast at the start of the dental show, which was just a few minutes walk away from the actual show. It was a champagne breakfast, and it was kind of, let's get a load of practice managers together and see what happens. Is there a need for it?
Yeah.
Do we want to come together? And do you know what? It was absolutely amazing, wasn't it?
It was
Just
incredible.
shows.
It was really, really good. And again, I mean, we had an hour and a half, but inevitably we didn't necessarily start bang on time because the practice managers were already talking to each other before we started. And I actually think we could have gone on all morning, actually. And a lot of the feedback said that the managers would like to have had a longer session. So I think that's very useful to take forward. And then you were actually, should we just, Nishu has a question or has her hand up. Did you want to ask a question?
Nishu, have you got a question, or have you accidentally popped your hand up? I think it might be accidental. But
Okay.
if I could
Yeah.
just, if we say, for anybody that would like to ask a question, as always, please do interrupt us, otherwise we go on forever. And you can pop that in the chat box at the bottom, and we will come to that. Absolutely. So yeah, it was a great session, and we hope the first of many, and we're gonna hopefully get some regionals. Thanks, EJ.
Yeah, definitely. And actually, the bit that we did just before you arrived, Lisa, was a real eye opener to me, because I started the session by asking everyone ask the practice managers what their biggest challenge was in practice, and I was really quite taken aback and surprised by the overall view that managing I'm going to call them work shy younger team members was everybody's the thing that really resonated with everybody, and we had quite a long discussion about that. And I think, as I say, I was a bit surprised that was the biggest concern. But I think that if you have got younger team members that kind of think that it's just a 9 to 5 job, and they come in and do their job, and they can do it the way they want and be on social media when they want, it's a massive challenge. And particularly given the recruitment, should I call it a crisis? I don't know, the recruitment situation where getting recruiting people is just so difficult at the moment. I think it's a real concern. And also, I think it plays into something we were talking about before we started today, Lisa, which is, you coming across so many practice managers who are still doing everything themselves, and rather than delegating. Now, obviously, some practice managers really sort of make their own lives a bit more difficult than they need to do by not delegating. But if a practice manager has a team that they don't feel they can delegate to, it's quite a big problem, isn't it?
Oh, massively. And I have multiple conversations with practices that I support, and also members of Adam that reach out as well. And it is across the board. And I think there's a couple of ways to look at this. It's okay, there is definitely a generational considerations. I think we have to sometimes understand that it's not always a behavior problem. It's a generational, not a problem, consideration, I think is the word.
Yeah.
And how we approach them as managers is really important.
Yeah.
Because one size doesn't fit all, particularly with
exactly
what motivates these sometimes younger generations. And for me, being an older generation, I'm a see it, say it, sort it type of person, type of manager. And I find leadership better and kinder and more effective if it's direct and open, and like you say it, say it, sort it. Because what's happening is it's rippling through other people in your team. Maybe some high performers will just get really, really fed up. And we've got to just tackle these individually and set the culture. And I think once you get that, people know that if something's not right, it's going to be dealt with, it's going to be sorted, not in a confrontational way, but in a direct way. It sets the tone. I'm like, why are we going round and round and round and expecting a different outcome? We need to sort it. And it might be a very honest conversation of, this isn't the right person for the team. Don't lower your standards, make people come up to the standard that you want. And I suppose that kind of sort of goes in line a little bit with a couple of the things that I was thinking about today. Being, quite at the moment, compliance isn't as much clinical. It feels it's not as much clinical as it is HR. With the Fair Work employment changes coming in, and the SSP and things like that, we have to be able to manage our teams and their standards effectively and precisely, with the knowledge that comes with the HR side of things. I know the last chat we had a few weeks ago was with Sarah, Lizzie from Buxton Coates, and I think sometimes people think of compliance as just being clinical.
I think you're right. They do, but it goes across the board, and it's such a broad thing, compliance. So, sort of, without wanting to state the obvious, you go all the way from infection control through health and safety, through healthcare waste, through ionizing radiation, which we'll talk about a little bit today as well, and then patient records and consent and confidentiality and data protection. And then there's all the team requirements as well. So you're completely right, Lisa, that the HR, and I'm going to call it HR rather than employment law, because employment law is a whole different ballgame. but in terms of the HR requirements, which come from the changes to employment law, which are, as always, immensely complicated, I think there's a whole lot to it, but it all adds up to whether the regulator thinks that the practice is safe, effective, caring, responsive, and well led. And obviously, the HR parts of that really come under well led, and that is the bit that, along with safe, those are the two areas that practices most commonly stumble with.
I think that's the thing, and our everyday practices, like managing people that aren't performing as well as we need them to, particularly sometimes it's not always the younger generations, but that does seem to be what most managers struggle with a little bit, mainly because probably there is a slight generation gap, and we can't, when you try to understand why someone's behaving in a certain way, and you can't, just because you're wired a little bit differently, and you have to kind of take a step back.
Yeah, it does make it very challenging though, doesn't it? It really does. And actually, I think so I heard a story not long ago about a young dentist, a resident house surgeon. Now, I did a resident house surgeon's job when dinosaurs were roaming the earth, and you were meant to be available 24 hours a day. And woe betide you if you decided you were going to clock off and only do 23 hours in a day. Goodness me, the professor would not be pleased. So that there was that mindset, and I knew what I was going into. And the story I heard recently is about a young resident house surgeon, and he was assisting the consultant at an operation, a maxillofacial facial operation. And at 5 o'clock, he downed tools and walked out. And the consultant said to him, "Where are you going?" And he said, "Well, my contract finishes at 5 o'clock." Now, in the old days, that would never have happened, because you knew what you were going into, and you kind of just put up with it. Now, that's not the way things are now at all. So I think it's as you say, it's very difficult to get your head around that. It's very, very difficult to get your head around that when you've lived in a different culture and still have that. I mean, if somebody contacts me on Christmas Day, if a practice is in trouble, then I answer their concerns. That's not how a lot of people operate these days.
No, and I look back, I hear lots of sort of older nurses say, "Oh my goodness, back in my day, they look after their clinicians differently. They're making them drinks, they're they're in early to make sure that the day goes that little bit smoother," and all of these things. And I think, you have to kind of go, was that right? In the younger generation, sometimes they're not doing anything wrong by being more transactional. You pay me, I do this. That's in my contract. And it's not that, I know people bandy around names and snowflakes and, oh, my day, we worked harder. And, apparently there was some study that said for the last 400 years on record, every generation has thought that people a year younger than them are lazier than themselves. It's kind of just a thing. But I think in practice we have to sometimes step away from, well, I should have, and I think they could have done this, and actually have a conversation.
Completely agree.
To establish what are the expectations, and sometimes you can meet in the middle, because they don't necessarily think, yes, there are the CBA brigade, the Can't Be Arsed brigade out there, inevitably.
I love it. I'm going to use that.
But then, sometimes it is just a different way of thinking, and we have to be exactly clear on our expectations. And then once they're set out and everyone's in agreement, it just feels a much easier relationship.
Yeah, definitely. Well, I think it comes back to your point right at the start about having an open and honest conversation about expectations, doesn't it? Because actually, if this is such a massive problem, then it is up to you guys as managers to set the expectations in the first place and not just expect people to know what the expectations are.
And when you've set it, you've kind of got that agreement, and it can be almost like a written agreement. You know, you can
Yes, sure.
document as our wonderful friends at Buxton Coat say, document these conversations. If it's documented, it's been done, and it's stronger. And you know, consistency. So if it's still not right and you're still not happy with the way something's going or someone's behaving, come back to that conversation in a couple of weeks. Come back to it again in a couple of weeks. Don't just set it and then hope for the best.
Yeah, exactly.
It just, you have to put that little bit extra work in until it sticks and it becomes a habit. Or you end up parting company. It's one way. But going round in circles, moaning about the same thing, for me, I'm like, I just got the energy, you know.
No, all the time, actually, Lisa, because it's immensely time consuming.
Yes, yeah.
No, I agree.
Pat, we wanted to touch on the new IRMA regulations. And we can most definitely do that. We've got a couple of questions there, and I thought might be good just to keep on top of.
Should we do the questions on the way through?
Okay?
Yes, absolutely.
Right? So we've got, please can you clarify the position of Oliver McGowan training? Can self-employed associates get any of the funding for part 2 of the in-person course from LDSS funding? How frequently should they be updated? And when is the deadline for when the course needs to be done?
Yes, absolutely. Thank you for asking that question, which is it's very frequently asked at Dentistry Compliance. You know, what is the situation with Oliver McGowan training? So the situation, as I understand it today, is that, and I have had a conversation with the senior dental advisor to the CQC about this, and I think it's a the CQC is taking a far more reasonable, rational approach to it than not. And so the situation is that not everybody has to have this training, and their approach is that you should risk assess in the practice and decide who maybe does need to have it. So part 1 is available free on e-learning for healthcare for everybody, and it's online, and really it's ramping up your CPD hours as a dentist or dental professional, so why not do that? But then in terms of the part 2, then I think it's a case, and the part 2 courses that there are very few and far between. The BDA is still saying that hopefully, and I looked the other day, maybe a couple of weeks ago, they are still saying that courses will become available later this year. So there isn't even actually that much training around in this. And I think that my contact at the CQC said that it's hard to argue that nobody needs level 2, that the part 2. But does everybody need it? Probably not. So maybe just a couple of people from the practice doing it, and wouldn't have to be a self-employed associate at all doing it. Maybe the practice manager, maybe the safeguarding lead, maybe the principal, but not everybody needs to do it. This is, as I say, this is hot off the press recently from the CQC. So
interestingly, Pat, sorry to interrupt. Interestingly, I had an email through yesterday about a course provider, and it's training the trainer, and it's offering to train people who can then train the rest of their practice.
Yes.
And it was about £500 for this course, and I've kind of put it aside to look at it properly. I'm going on holiday tomorrow, so I'm trying to cram.
Sure.
Okay, that can just wait until I get back. That's fine. And I thought, do you know what? It might not be something that makes sense or is practical, but it's definitely, hopefully, it's a consideration.
It is a really good consideration. And to ask our questioners, answer our questioners' question, can self-employed associates get any of the funding for part 2? I don't know the answer to that. I think not, but I don't know the answer to that, I'm afraid. Do you know, Lisa, or shall we do some research and then come back at the next session?
I think we start, in my head, I'm going self-employed, that I'm starting to go off in HR and
I think there is, I think the answer is no. And actually, whether you should even be thinking about that or not, because it protects your self-employed status if you pay for your own CPD.
Yeah, we will research into that, and anything that we find, we will pop that through Adam.
And Jackie's saying that I'm the safeguarding lead for 24/7. Would this be something I should consider completing, Pat? Yes, I think so, Jackie. I think that given that you have a lot of practices that you work with, then I think it would be entirely logical for you to be the one that does this and then disseminates the information to the team. And, you know, I think this idea of train the trainer is really good as well. So maybe that would be something that would be something that you should do. Both parts, yes. Yes, it's level 2. It's part 2 I'm thinking of here. So yes, I mean, there is no reason why anyone should not do part 1, because it's free and it's on e-learning for healthcare. So I think just as a matter of interest, as much as anything, you know, so that you actually know what the training is about. So and I think, just back to Decky's point, I think the safeguarding lead is probably the person that should do it, and then disseminate the information in the practice. And I really like the idea of a train the trainer program. So maybe we'll have a look at that, Lisa, and see what it looks like.
Yeah, absolutely. I think that'd be really helpful. There was a bit of feedback there. So Irma.
Oh, Lisa, I have spent weeks and weeks and weeks.
I thought you were quiet.
Buried in Irma. So we have on Dentistry CPD, we have a series of courses, which, if you do them all, will give those that need it their 5 hours of Irma training. And so I spent hours and hours and hours updating that. I then, for my sins, then ran a one-day Irma interactive course for the NHS Business Services Authority clinical advisors. Now, my biggest fear in life presenting is that everyone will fall asleep. So given that Irma is the most boring subject on the planet, I was determined to create a course that nobody fell asleep in. And so I made it interactive, but I digress slightly. So yes, there has been a big change, big-ish change to the Irma regulations. And this is what you do need to know as practice teams, is that there is much more focus on the employer, and the employer has much bigger responsibilities than they did before. So this is your practice owners, and you know, the onus now is on having the right written policies and procedures, on ensuring that you've identified what the regulations refer to as duty holders. So those are people that hold the various Irma duties. So that will be, obviously, there's the employer, then there's the referrer, that's the person that refers for the X-ray. There is the practitioner, who is the person that justifies it and authorizes it. Then is the operator, who could be any, and they have a broad range of tasks that they can do, provided they're appropriately trained and entitled. So there's a lot of stuff about making sure that everybody is appropriately entitled, and for that you need an entitlement register, really, so that it says, okay, in this practice, Lisa Bainham can do this and this and this, and the employer must officially entitle her to do that. So that's quite a big important change. So you've got the operator, and the operator can vary between the person who presses the button, provided they're entitled, and by the employer, and that they've got appropriate documented training, or it could be the person that refers for the X-ray, that justifies the X-ray, that authorizes the X-ray, that takes the X-ray, that reports on the X-ray. So it could all be the same person, but it's quite a big change from how it was before. And then there's a lot around separating out what IRMA is from what IRR 17 is. So yeah, I've spent weeks and weeks and weeks on that, but that's really in a nutshell what it is. Plus also there is more stringent guidance on what happens if you have an accidental or unintended exposure. So that is making sure that your X-rays are graded appropriately, and that any obvious, if there's any clinician or dental professional taking X-rays that are frequently classed as not acceptable, then looking into that and making sure that measures are put in place to make sure that that doesn't happen, because otherwise you have to keep taking X-rays again. And the whole objective of this is to make sure that patients don't have to have unnecessary radiation doses. So that is in a nutshell. Muna has asked, am I doing any webinars I can book? Yes, indeed, I am. I think I will be doing the IRMA one for dentistry for FMC in November, but I'm certainly, probably September. I'm doing changes to the CQC registration at the beginning of July, skipping August, and then I think we'll go for IRMA in September. CBCT rules. And Natasha, could you just clarify what question you're asking there in terms of level 1, level 2? Natasha, can you just let us know what it is? Right, I don't know the answer to that either, actually. Level 1 training, who needs it? Level 2. Again, that's something we'll research for you. Do you mean in IRMA, or do you mean in, I think you mean in taking CBCT, in authorizing CBCT? There's a lot of additional training required for people who refer for CBCT, who take the CBCTs, and you have to do training in diagnosis and reporting for CBCT. So there's a lot of extra training involved in CBCT. Does that answer your question, Natasha, or not?
Potentially, it'll be interesting to see what the changes are. We take referrals for CBCT, and we have an agreement. We set up an agreement with the referring practice. It does get complicated, you know, the number of dentists that refer to us that haven't got the appropriate training it still does shock me a little bit.
Yeah.
Luckily, we are a practice that likes rules.
Yeah, absolutely. Absolutely.
Yes, we do. That is part of the agreement, where they have to show us evidence of it. And then you've got the whole reporting thing. We're a referral practice and do a lot of implants and such like. So we do actually make sure that we are sticking to what we need to stick to. It'll be interesting to see if that changes. I don't think it does. I mean, if most people's CBCT providers will do the training, and it's pretty low cost, in all honesty. As a practice, we held an evening and we got them in, and we helped people with that because we want them to be able to refer. But even us, as with we've got very advanced implant service, and we send our CBCT scans to a company. I don't think it'll hurt to say it, but we use Dental Scan, and they charge us 60 quid to report. I'm not clinical, I'll be absolutely honest, but when I hear the clinicians talking and being concerned, there is a risk, and you need to talk to your indemnifiers, because apparently if you're only reporting on a specific thing in the mouth, if there's something else there that gets missed, there's liability. It gets very, very
Yes, it does.
complicated.
It does. And I do worry quite a lot about people who refer to scanning centres and it may not be referring, because in order to refer, you have to be providing sufficient clinical information to justify the exposure. And I'm not completely sure that that is happening all the time. So you can't just say, please take a CBCT. That's not allowed.
No, our referral forms are quite detailed, well, very detailed.
Yeah.
And they don't get far without without that detail. And quite often it's a follow-up call as well, if there's any bits of detail missing. I think it's one area that you just don't mess about with at all. So Decky's put, I had a compliance manager for one of our host locations ask me for the list of all our operators, so she could set up separate local rules for our staff and display them in the surgery that we use. The policy has been sent to me and I have requested that they all read it and sign to say they have. Would this be acceptable as an entitlement register?
No, it wouldn't, Decky. So, and also, local rules are set by the Radiation Protection Advisor in line with the requirements of IRR 17. So they can't set up separate local rules. Local rules relate to the machine and the controlled area. But so in terms of the entitlement register, it is literally just a list of everybody that you work with that says what they're entitled to do. And in order for them to be entitled, they have to be able to demonstrate that they've had the right training for the role. So somebody who is just pressing the button needs to have training that reflects a record of training that reflects that they've been trained in how to press the button, right up to sort of somebody who's a dental professional who's been on a radiography course and is entitled to by the employer to do all the everything. So act as practitioner, act as operator. So I think that in terms of I think that you need to have a list. What I suggest you do, Decky, is that you have a list of people, and then what it is, because you're not the employer, you're the employer of the people that go into the practice, but you're not the employer as in the practice owner. So I think it needs to be a conversation between you and the practice that says, look, these are the people that we have coming in to take x-rays. This is their training. We've entitled them our end, and then the employer, I think, in the practice, or the practice owner, then probably needs to entitle them separately. But it'll be up to you guys to provide the right information that says whether these people on your list are entitled or not, as in, have they got the correct training? Yes, I think you're right. She has not understood IRR 17.
Thank you. Just flipping back to what Natasha was talking about, having the referrers level 1 is great. If they choose to do level 2, that's also great. But I would encourage, as their managers, I would encourage them to speak to their indemnifiers.
Yeah.
If they're going to be, even if they've got level 2 and they're reporting, as I mentioned, I think there is a real vulnerability there. There'll be some dentists that go, oh, I'm fine, I can do anything. From a practice point of view, I think you have to, I don't want to upset people here, but think about vicarious liability.
You do. You absolutely do. I think it's very important to say that, Lisa. I do. And actually, you know, so you've got experience then of people referring to you, just please take a CBCT. Is that happen? Yeah.
Well, and we want to know, well, who's reporting on it? And you just start to get it starts to get a little bit messy.
Yeah. And why do you ask them that they presumably they have to justify to you why they think, provide the clinical information to justify it? Yeah.
Yes, absolutely. And we help them. Our clinicians are massively experienced. Some just do implants that the whole time they're here, and they steer clear. So we've all probably come across dentists who, sometimes very little experience in certain things and think they can do this and that and the other. And I worry. So Natasha, if you want to go back and say, well, Lisa and Pat said, you can use us as your buffer if you want to. But all we're saying is just speak to the indemnity, find out what the sensible way to handle this is. Because it's not the same as even normal x-rays. It's
you're very welcome. Thank you, Natasha. Right. Next.
What have we got next? New Pat, we've got a bit of a surprise, haven't we? So we're going back to, there's going to be a new old framework.
Yeah. So currently we're supposed to be, CQC is supposed to be in their new single assessment framework, which in my very strong opinion is not really any different to their old framework, because if at the end of the day, they're coming to see if your practice is safe, effective, caring, responsive, and well-led. And the things that make that up are the things that have always made that up. So safe is all around infection control, health and safety, healthcare waste, it's radiation protection, it's all the things that go to make up safe.